And what I'd like to do tonight is to just talk a little bit about how the techniques of imaging for ischemia and imaging for atherosclerosis are complementary. I think that we've heard a lot about the early detection of atherosclerosis in patients with subclinical disease tonight. It gives us this opportunity for more effective prevention and potentially eradication of the disease of heart attacks. Then in the patients in whom we are not so early, where there is active ischemia, we need to define those who can benefit from revascularization as well as from medical therapy. And in that regard, we don't go straight to angioplasty or bypass surgery because they're not without risk. We need to determine who might benefit. I think that we are in the midst, based on the non-invasive imaging strengths, of really seeing some definite paradigm shifts in the way we approach patients. Instead of thinking about risk factors, we are now talking about disease markers. Instead of talking about detection of stenoses, we're talking about identification of patients who are at risk for short-term events. And then instead of just talking about risk assessment, we're talking about identifying those patients who might actually benefit from a procedure. Not only are they at risk, and there are opportunities in these regards for multimodality imaging. Now first, just let me mention nuclear cardiology. It is a very strong component of the current mainstream cardiology practice. We use nuclear methods to evaluate the extent and severity of perfusion abnormalities. And as my colleague, Dr. Rory Akamovich, recently added to our armamentarium in this regard, when we look at the extent and severity of a perfusion defect by grading the scores of the segments that are shown in this slide, we can then normalize by the maximal score possible and end up with a statement to the clinician about the percent of the myocardium that is hypokinetic, that has stress perfusion defect, the percent of the myocardium that's ischemic, and the percent that has infarct or that is a fixed defect. Any clinician, if you tell them that 20% of the patient's myocardium is ischemic, would know what that means intuitively and would act on it. It doesn't really matter whether we're talking about 17 segments or 20 segments or 14 segments or 12 segment analyses, and all of these are common analyses for the nuclear data, because if you normalize for the maximal score, you can end up comparing the different approaches. We recently published on 16,000 patients that we followed at Cedars-Sinai for 2 years. The number here of 16,000 illustrates to us that nuclear cardiology is a mature technique with a lot of outcomes data. And we show, plotted horizontally, the percent of the myocardium abnormal at stress, and then vertically the cardiac mortality rates per year. And we see the strong relationship between the extent of that defect and subsequent outcome. Based on many centers' data in over 70,000 patients now, reported with this medium-term follow-up. We see that the nuclear test is effective in defining events over a few-year period of time. Not 10 years, the way we can talk about with coronary calcium, but a shorter term. We can define those patients who are at need for consideration of revascularization in a broad spectrum of patients. And by virtue of the fact that we can image ischemia, or how much myocardium is reversibly ischemic with stress, we have an opportunity to predict who might benefit from a revascularization procedure. There's an article in circulation first authored by my colleague Akamovich again, based on Cedars data, where we looked at what were the drivers to revascularization. And it turns out, if you looked at the likelihood of revascularization in a multivariable model, 83% of the information that we could derive, anyway, in the patients who were referred for testing, came from how much myocardium was ischemic. And clinicians seemed to know that 10% ischemia was an important number. Well, in a sophisticated way of adjusting data for using a propensity score and then standard risk adjustment, you can then take information such as what leads to revascularization to allow you in an observational database to compare different therapies. In this slide, we compare revascularization in white to medical therapy in red, and we see that right at about 10% ischemia, there's a crossing of these lines. Death rates are plotted vertically. In patients who have very little or no ischemia, the death rate in a patient undergoing a revascularization procedure is actually higher than the patient, on the average, who undergoes a medical therapy. On the other hand, in the patients who have a lot of ischemia, there's a clear-cut benefit for revascularization over medical therapy, and this actually holds throughout a broad range of ejection fractions. Recently, what we've done is to be able to illustrate that if you have a patient with a very low ejection fraction, we can say that that patient is in a high-risk group. But the likelihood of benefiting from a revascularization in the patient who's in a high-risk group depends on how much ischemia is present. Now, it's not just the ischemia, of course, that determines whether or not you revascularize. You have to take into account a lot of non-nuclear and other kinds of nuclear findings in making these determinations. Now, how does this all fit together? I'd like to start at the opposite end of the spectrum from what we've been talking about tonight. If a patient has a high likelihood of coronary disease but doesn't have disabling angina, minimal angina, or just as through non-invasive, let's say, stress testing, is found to have a high likelihood of coronary artery disease, where do we go? Stress imaging, either stress nuclear, stress echo, appears to make sense in these patients. If they have extensive ischemia, they're going to be revascularized. Mild ischemia, it depends on the patient. No ischemia, that's a question. Come back to that in a second. Nuclear techniques allow us to identify this benefit of the determination of who can benefit from revascularization. So it's got a high technical success rate. We can objectively quantify ischemia, and it's commonly used, even by the most invasive cardiologists, to determine who needs to consider a PCI. It's interesting, over time, we found that the invasive cardiologists are the number one referrer to patients, to non-invasive testing laboratories for ischemia. Limitation of ischemia testing is we're not going to detect the early patient. We're not going to detect the patient who might have the problems 10 years down the line. We're detecting the patient with a short-term, with respect to short-term risk, and we can at times underestimate the extent of disease. Tonight we've heard a lot about calcium. It's the most accurate test for the early assessment of coronary atherosclerosis. We heard about the relationship between plaque burden and coronary calcium score. We know that if you have a normal calcium score, it's very unlikely that you'll have a coronary stenosis, but just having calcium doesn't mean you'll have a coronary stenosis. But we know that there's independent incremental information over risk factors. Many speakers addressed that tonight by looking at the calcium measurements. You've already seen this data that came from the Paul Raji and Tracy Callister's data. In both men and women, the calcium score is predictive. I wanted to emphasize that it's very predictive in the patients who have intermediate Framingham risk, but it's actually predictive in all three of the patient groups. But from a cost-effectiveness standpoint, that intermediate risk group is clearly a group identified as benefiting from the different coronary calcium scores. And these scores help us determine to be aggressive with patients with medical therapy. Who do we have to be most aggressive with? And then importantly, what I'm emphasizing tonight, do you need more testing after you've had an ischemia, after you've had an atherosclerosis scan? So the opposite end of the spectrum, a patient with very low risk, well, none of us are going to talk about actually doing an imaging test on such patients. They're very low risk. But the patients who are in the intermediate risk, if they're asymptomatic, we've heard tonight a coronary calcium score makes sense. Those with scores less than 100, primary prevention, scores 100 to 400 or greater, secondary prevention, a greater than 400 score, data suggests that those patients have an intermediate to high likelihood of having an abnormal SPECT scan. So when your score gets high enough and you're asymptomatic, ischemia testing appears to make sense. The article earlier referred to tonight in JACC just earlier this year, we evaluated approximately 1,200 patients who had SPECT scanning and EBCT or coronary calcium scanning. And this slide horizontally illustrates the standard calcium score categories, and vertically we're showing the percent of the patients who had ischemia by nuclear testing. And what we found is that if they had a score that was over 400, then the likelihood of being in an intermediate risk of having ischemia was there, and that patient maybe would be appropriately defined for referral for nuclear stress testing. You begin to see a rise in the 100 to 400 group, and in that group it really depends on which patient you're talking about. At the American Heart meetings, Nathan Wong, who works with us, has already been mentioned tonight, he works with us in a consulting capacity on a grant we call the Eisner study, has evaluated the patients in the 100 to 400 range with respect to their metabolic status. No metabolic abnormality. In red are patients with a metabolic syndrome, and in green are patients who have diabetes. And we see in the 100 to 400 category, the percentage of patients having ischemia is as high when the patients have the metabolic syndrome as it is in the greater than 400 category when there is no metabolic abnormality. So patients with the metabolic syndrome might be one of those patient groups where even in the 100 to 400 range, it might make sense to go the direction of doing a nuclear study after a coronary calcium scan score has shown either an intermediate or a high amount of calcium. Finally, let's get back to that question mark that I raised earlier. What if you've come in by having some symptom that was suspicious or maybe flunking a stress test, and you get a direct referral for ischemia testing, and you find no ischemia? What do we do then? Well, in our study, the most interesting findings, I think, were in the 1,100 plus patients who had SPECT and calcium scanning and who did not have an abnormal nuclear scan. In that population, we're showing on this slide the frequency of the various different coronary calcium scores. 56% of our patients with normal stress myocardial perfusion studies had coronary calcium scores over 100, which has been defined tonight as being a prognostically important level where aggressive medical therapy would be appropriate. And if you don't like that cutoff, you want to be even more conservative and you say it's got to take a score of 400 or greater for me to be very aggressive with medical therapy, 31% of our patients fit in the group of having extensive calcification and a normal nuclear scan. So what we now believe is that if you had enough indication to go for a nuclear scan in the first place, and the scan is normal, that instead of stopping there and giving the patient a clean bill of health, going for a coronary calcium score afterwards to determine how the patient should be managed makes sense. So if I just use a couple of examples, this is a 70-year-old physician in our hospital, asymptomatic tennis player who undergoes a nuclear scan, and the nuclear scan is entirely normal, and with a normal nuclear stress test, pardon me on this, with a normal nuclear stress test, what happens? Nothing. He doesn't change anything after that. But John Friedman, who's in the audience here, says, well, why don't you come have a coronary calcium scan? And he's 70 years old. He's got a couple of young kids at home. He's actively playing singles tennis. Come have a coronary calcium scan, and his score is nearly 3,000. And at that point, he does a lot of things in modifying his risk. And for 6 years now, he has been on active risk factor modification, aggressive medical management, and he's still pain-free, still actively playing tennis, and has never been catheterized. Never had coronary angiography. So the myth that patients are going to end up with coronary calcium and everybody's going to go to the cath lab is simply that, a myth. Another patient from our study, 70-year-old doctor who's diabetic, comes in for a nuclear scan, and his scan wasn't quite so normal. His scan was one that demonstrated a finding that I'd like to illustrate to you, but I've got to get it here. He has on his study a subtle defect in the lateral wall. We didn't know quite whether that was abnormal enough for us to consider as being enough to send him to the cath lab. He also had anterior wall hypokinesis at stress compared to rest. But it was really quite a subtle finding, and John and I sat there wondering what should we do. And we said, well, let's send him to the Eisner study. Let's get him a free coronary calcium scan. And the result was a coronary calcium score of 1,300 and dense calcification in the left main and LAD. And now in this diabetic patient who has subtle abnormalities in the territory of the left main, including wall motion abnormalities, he goes to the cath lab where he's found to have a 75% left main stenosis, and he had bypass surgery. Now, all this not perfect. The last case I could show you here is a patient who comes in, but he's got angina. And he has a result on his nuclear study showing this finding, where the left anterior descending coronary territory is essentially missing. You can define this quantitatively as a very large defect throughout the left anterior descending coronary territory, and it's associated with abnormal contraction in the LAD at stress compared to rest. It was a 64-year-old man with angina, recent onset, sounded like angina. On the way to the cath lab, we said, join our Eisner study. Let us see what's going on in your coronaries in terms of calcification. He says, okay, I'll do it. He has a calcium score of 7.5. Not all plaques that are unstable will calcify. Nothing is perfect. But as we've heard, most patients who have enough atherosclerosis to be vulnerable end up having coronary atherosclerosis of high degree. So finally, I would just mention that there's a group of patients then, somewhat exemplified by this patient with chest pain, who actually have symptoms. We're not talking now about the asymptomatic screening application, but patients with an intermediate likelihood of having coronary disease, but presenting with a symptom that's suspicious for cardiac disease. And in that circumstance, we're no longer screening. We're really doing diagnostic testing. It may be coronary calcium scanning, it may be CT coronary angiography, it might be in the future MRI, it might be gated SPECT that should be the first test. We don't really know yet where that patient, how to test that patient in the most cost-effective manner. To end then, I think that non-invasive imaging plays a very important role in guiding management decisions in patients with either known disease or with suspected disease. The non-invasive imaging advances are facilitating paradigm shifts from early detection of disease, from just into the early detection of disease and this assessment of risk and benefit. Which test to start with depends on the clinical question. If it's the asymptomatic patient where you're trying to define the need for aggressive medical management, coronary calcium scanning, IMT, that appears to be the start. In a patient with either coronary disease or suspected coronary disease based on symptoms, where the question is this symptomatic stenotic disease that might be associated with ischemia, then it might be coronary calcium, but maybe you'd be starting either with a coronary CT angiogram or with a SPECT study. If the question is there a need for revascularization and you're trying to define benefit, probably defining ischemia makes sense. And in an area we didn't talk about tonight, at the other end of the spectrum, patients with head infarcts, you're trying to decide should they be revascularized or have a ventricular reshaping, then viability testing is important, and MRI probably plays a strong role there. I think as time goes forward, we will see these and other tests of imaging studies of either function or not, even non-imaging studies that look at a function will be allowing us to expand our ability to identify the patient who needs various kinds of treatment. And what I've tried to do in this short time is to indicate that at least in our findings preliminarily we could say that these different tests are clearly complementary in many settings. Thank you.